Welcome to Health and Harmony Beyond the Teeth, where we dive into all subjects that will help you become healthier and happier. As a dentist, I believe dentistry is more than just teeth, so I created this show to focus on overall health. We will hear from leading experts about eating better, exercising better, breathing better, and sleeping better. We want to help you create harmony in your life so you can live your life to the fullest. We want you to thrive.
Hello, everyone. Welcome to the Health and Harmony Beyond the Teeth podcast. My name is Alex, and I am taking over as today's host. I am Dr. House Stewart's daughter, and I am a mom of 2 children. I'm very passionate about overall health, and especially sleep breathing disorders. And I think that this is a topic that a lot of parents just aren't well informed on. I think it's a topic that a lot of providers also aren't very well informed on. And so the hope behind this episode is to just answer some frequently asked questions and give some guidelines on how you as a parent can navigate this topic. And so we are joined today by my dad, Dr. House Stewart. How are you doing today?
Good morning, Alex. I'm doing great. How are you?
Good. I'm doing well. Thank you. Well, I'm excited about this. I run an Instagram account that's geared towards parents, and I feel like I have conversations with parents every single day about sleep disorders, ADHD, tongue and lip ties, and I just realize a lot of people just don't know what they don't know. And I think that this will be a really great resource to be able to send to parents. So I want to start, there's a couple of different sections I kind of want to cover, but I want to start specifically with oral restrictions. And so a little backstory. For me, when my son Miles was born back in 2021, in the hospital, my doula told me he had severe oral restrictions. Then the pediatrician at the hospital came in, told me no restrictions at all. Everything looks great. Then we met with an IBCLC a few weeks later, and she said, well, there might, be some slight restriction there. And so thankfully I knew what I knew. You were my dad, so I didn't have to worry about what anybody else said. But for a parent who doesn't know what they don't know, that could be very confusing and very overwhelming. So my first question was, are there any sort of red flags that parents can keep an eye out for that might hint that whatever provider might be saying X, Y, or Z when it comes to oral restrictions I don't want to say might not know what they should know, but maybe would warrant a second opinion?
Yeah, and I'm glad you asked that question. If you'll recall, we were over your house one day, and my wife, Dr. Adriana Corridor, did as thorough exam as she could on a 2-week-old child regarding our grandson Miles, and it appeared the first appearance was that he did have a restriction, but upon further, she did some other testing and things like that, just not running blood tests or anything like that, but she's very well trained on that, and in her opinion, and he wasn't having a nursing issue or anything like that, and so um, she had determined that she didn't feel like he had a restriction. And so a lot of times it can be and the provider can be have the best intentions, but if they're not well trained, if they're just looking at tissue, and I would say one red flag would be just a cursory exam. They just open the lip up or lift the tongue up and say, yeah, it looks like there's a restriction. I think you should do something. Because things are not always what they seem. So the same for children, the same for infants, the same for children, the same for teenagers, adults. It really needs to be determined by someone who has the proper training and who does a thorough exam. And it's something more than just a cursory look. And so one of the red flags would be for a child or older if there's no mention of myofunctional therapy, because we won't do a release on a child over the age of 4 unless they have worked with a myofunctional therapist. and we'll probably get into myofunctional therapy later. But that's one of the things. Of course, an infant or even a 1 or 2 or maybe even a 3-year-old might not be at the point where they can really do myofunctional therapy. I think a lot of 3-year-olds probably could, but 1 to 2. So I'm not including those age children in that. But any older child, 3, 4 or older, if the if you're told by whomever that, hey, this child needs a tongue release or lip release, let's just go ahead and get it done. Well, that's a red flag, because we want to be working with a myofunctional therapist prior to the tongue release and after the tongue release. So just a quick look and a suggestion for a surgery that, it's a fairly non-invasive surgery, but yet it's still surgery, and it's not something to be taken lightly. So more than just a quick look, you need a good thorough exam. Speaking specifically for infants, there are different type of exams that I know Dr. Corridor does, and it's more than just a quick look. So that would be just you want someone who's doing a more of a thorough look see, not just a or more of a thorough exam, not just a look see.
Yes. And I do want to preface, for the purpose of this episode, we are going to be focusing primarily on probably that age 4 and up. We will do another episode with Dr. Corridors, specifically on infants, babies, and younger toddlers. Some of it will cross over to all ages. But yes, I want to acknowledge that. And I will at least preface here and say, for that more infant baby age range, um, while myofunctional therapy might not be appropriate, seeing an IBCLC, I would say, is a green flag, in a provider, which we'll get to in a little bit.
Yes.
Dr. Corridor pretty much requires an IBCLC, and I know the provider who did Evelyn's, my daughter's release, would not even consider performing a release until I went and met with the IBCLC that they work with. So that is an option for
Yeah,
that younger age range. And
that's
so,
a good point.
yes, you mentioned myofunctional therapy. Why is myofunctional therapy pre and post release important?
Well, it's like I my analogy is like a golf swing. If a child or adult, whoever the patient is, if they have a dysfunctional swallow, so the tongue is the strongest muscle in the body, and it's constantly at work. So the tongue is either going to work in your favor or it's going to work against you, is from a standpoint of development of the airway and the upper jaw. And so if there is a restriction in the tongue and the lips, though that tension is working against everything that we as a airway remodeling practitioner would be doing for our patient to try to increase their jaws to so they have a better airway. And so myofunctional therapy is a type of therapy that focuses on improving the function of the face, the mouth, and the tongue. And so we want to, just like I've had several surgeries on my shoulder, recently had a back surgery. My physician, my surgeon, had me do not myofunctional, physical therapy before my surgery, just to prepare the muscles and prepare everything better. And then, of course, after surgery, I will have physical therapy as well. So myofunctional therapy is no different. When a tongue tie and or lip ties are inevitable and need to be done, we want the patient working with a myofunctional therapist before we do the surgery. So we're already gaining that muscle tone. Um, we're strengthening. We're starting to retrain. Again, going back to a golf swing, if if you've been playing golf, for a number of years and you have a really bad swing, you're going to get a coach that's going to retrain your swing so that you don't even think about it. These pro golfers, their swings are so fluid and so effortless, and they knock bejesus out of the ball. I mean, they knock it, three, four, sometimes close to 500 yards. That's what we want to do with the tongue and the lips. We want to retrain the muscles so they're functioning not incompetently, but very competently. So we want to get that started prior to the tongue and or lip releases, and then continue it afterwards.
Yeah. Okay, that makes sense. So my next question was, and we're sort of moving into that, some green flags that indicates a provider,
Yeah.
is really looking at a whole picture. So
Mhm.
myofunctional therapy for older kids, IBCLC for younger kids. I know that body work is also a really big part.
Yeah.
Can you speak to that a little bit of why body work and specifically what kind of body work
Yeah.
for before and after a release?
Well, we refer to body work or craniosacral therapy. Craniosacral therapy is a very gentle, hands-on type of body work that helps release tension in the body, especially around the head and the neck and the pelvis. It's often used with children to support proper growth, and the cranial bones are all in constant motion, even in adults. They're not, we think of a skull with all these bones that are just tightly sutured together. But when we see a skull and like in a museum, that skull's been dried out and, oftentimes petrified. But in the body, those bones actually are dynamic and they move. And so they also have an effect on the what we call tensegrity, biotensegrity, meaning the stability of a body comes from its ability to move and to move properly. And, it's like when people get a bad knee or a bad hip, they can't move properly and they're more prone to fall and break things. So, biotensegrity means the body is in constant motion, it's moving very fluid. And so, a cranial sacral therapy or body work helps free up all of that tension that's in the head and neck area and really does help with the recovery. I don't want to say recovery, but the results from tongue and lip releases, because recovery from a tongue release is not like recovery from a shoulder surgery. I mean, our patients, we do sutures, and they can go back to their normal activities the day after surgery. But we want, as that's healing, we want the tongue to be functioning properly from day one. And so that's why we have craniosacral body work and myofunctional therapy prior to the surgery, so that from day one, when that surgery is done, the tongue is functioning properly. And it's actually, being trained to function properly. And now we've given it the opportunity to really train to function in the most optimal manner by releasing it. But the muscle memory is there from having the previous myofunctional therapy and the cranial sacral therapy. So I just think it's prudent for a practitioner to realize that the surgery itself is, while very, very important, it's only part of the puzzle.
Yeah. Okay. So I know that this will be a question. What can, because I know people will ask, well, can I just go see a chiropractor? Are there,
Yeah.
I mean, chiropractor versus osteopath, can they
Right.
both be trained in craniosacral therapy? It just depends on the
Yeah.
practitioner's training.
That's a good question. And it can get very confusing for patients, because and that's where we like to think at our clinic here as kind of medical central. I mean, we're not medical doctors, so we're not going to diagnose a deviated septum. Although I mean, I see it all the time, and I tell my patients, you have a deviated septum, or you have a cervical misalignment. I'm not officially diagnosing, but I see it. So we send the patient to where they need to be for that particular issue. But uh, craniosacral therapy is not there's not a certification for that or a licensing for that. What it is it's it's a subspecialty that usually massage therapists, physical therapists, occupational therapists, chiropractors, and osteopathic physicians, nurses, naturopathic medicine practitioners, and acupuncturists, and dentists will go and get extra training, and they will do they offer that service. Now, having said that, the we work with an occupational therapist on a lot of our patients that pretty much only does cranial sacral therapy. So she's doing it all the time. So that would be a question that I would ask if I were a parent or if I were the patient, looking for myself for solutions. If your dentist or whatever practitioner refers you to a cranial sacral therapist, they're not going to have a cranial sacral therapist, letters at the end of their title because there's not one, but they may have, the title for a physical therapist or an occupational therapist. I would ask that therapist, like the one that we use, that's pretty much what she does day in and day out. She has all this other training, but she is focused on craniosacral therapy body work. And so for what we need, that's what we're looking for. Someone that does that and they do it every single day, not just, oh yeah, I can do that. And yeah, I do that occasionally. You want someone that does it every day because it's like anything else. It's like playing the guitar. The more you do it, the better you get. And you need someone that's doing it on a daily basis. So whoever you refer to, ask that person, how often do you do this? How many patients do you see a week doing this? If it's, oh, I do this on a daily basis, that's great. If I see it occasionally every 2 3 weeks, it's pretty rare. So I don't do it that much, then I would probably stay away from that practitioner because the need for body work is prevalent. I mean, I see it probably in the need for that in 95% of our patients.
Okay. I want to throw out there, and I'll put this in the caption or the description as well. I think it can be overwhelming for a parent, that's going down this road of like, okay, well, I don't even know where to start. I don't know any myofunctional therapist, any body workers. Like, there's too many people out there, and I don't know where to begin. I have been putting together a huge master list by state in the United States, even a few out of the country of airway providers, myofunctional therapists, IBCLCs, and craniosacral body workers, just from different organizations that we'll get to in a second, that I at least know if this provider has been through this organization or been through this training, they at least maybe have more of an understanding than just your general practitioner. And so that could be a good place to start to see if there's somebody near you. If you go to your state and you see, oh, there's an airway provider here, but no myofunctional therapist, well, it might be worth asking that airway provider, hey, do you know of any craniosacral therapists near us? Do you know of any myofunctional therapists? Obviously, every provider on this list, we do not know personally. We can't vouch for personally, but I at least know they've been through some of these organizations or trainings that are pretty elite. So I'll put that in the description. And that leads me into the next question of kind of
Can
growth.
I address something before
Yeah.
you go to the next question? Because that's a great point, and I kind of started to say this, then I got sidetracked. But we at the Stewart Center for Optimal Health, we tell our patients we think of our as medical central, and that's why we are the Stewart Center for Optimal Health. We cannot do, and we're not trained to do everything that needs to be done, every therapy that needs to be included in a patient's treatment. We're not trained for that. So I'm not trained to do the Vivair, turbinate reduction in patients, or I'm not trained to remove tonsils, or I'm not trained to do craniosacral therapy. Although I've taken many courses, I don't do it every single day. I rely on people to do it. Having said that, my answer would be, I would find a really good airway dentist to start with. Dentist, and I don't mean to want to sound immodest about my profession, but dentistry knows a lot more about medicine than medical doctors know about dentistry. There are very, very few medical doctors. I can think of a few. Dr. Zagi, obviously at the TBI, the Breathe Institute in LA, who I've trained under extensively. He is a world-renowned ENT medical doctor who understands growth and development of the jaws and airway. But in general, you're going to find more information at a really good airway development type practice like we have. And then we send our patients out. Yes, you need to see a body worker. Here's some names. Yes, you need to see osteopath. Here's some names. Yes, you need to see the ENT or all of these other practitioners. So I would ask, my advice would be if you find a practice like that, ask them who their team. Do they have a team of professionals to whom they refer? Because we do. We have a team, and it just grows bigger every week because we see new patients who are working with this body worker that we've never heard of, but they're doing phenomenal things. So we just add that to our list. And so I would ask your, I would start with an airway dentist and then see if they have a team. If it's no, we pretty much do everything ourselves, then they're only doing the limited they're only looking at limited things, and you need to have a do a global diagnosis of what is going on here, but how it's affecting the rest of the body and where that patient needs to go.
Okay. Yeah, definitely. I know I used to be and still am a little skeptical about ENTs. I think that is another popular question of, well, should I go to ENT or dentist route? And after hearing Dr. Christopher Tran speak at the Myosphere, he's a
Mm.
ENT out of Houston. I was like, okay, well, and I know Dr. Zoggy's an ENT. I was like, maybe not all ENTs, you know.
Yeah, it depends on the ENT. Yeah, because
But
if you went to Dr. Zoggy or Dr. Trend, they would look at everything and they would say, you know what, yeah, you've got a deviated septum, or you need myofunctional therapy, you need to start nasal breathing, we can help by reducing the turbinates. But one of the reasons why you have this congestion in your nose and you can't breathe is because your maxilla, the upper bone, did never developed correctly, and you need to get that developed better by an airway airway specialist type dentist. And Dr. Zaghi refers, he's got these people there in LA that he refers to. Most ENTs don't do that. So I would rely upon the dentist first about diagnosing, and then have them send you to an ENT who's very airway focused.
yeah, I think that's great. I know I get that question a lot.
Yeah.
Okay, so a little recap, we covered some green flags. If you're seeing an airway provider and they're, mention specifically, we'll focus on sleep disorders later. And I know ties, oral restrictions play a part of that, but focusing on just tongue and lip tie, buccal tie releases, if the provider is, talking about myofunctional therapy, IBCLC, craniosacral therapy, these are all green flags of
Yeah.
okay, this doctor understands the team whole body approach. Are there certain, I know there's a lot out there, and we probably can't get to every single one, but are there any sort of top trainings or qualifications that somebody could look for of like, oh, this doctor has been through this training, this could be a good place to at
Yeah.
least.
Yes. In the United States, and I don't know every single training um, protocol out there, but I do know for a fact that the two premier, if I go to a practitioner or if I have a patient saying, "Hey, we moved to wherever, and we found this doctor, and he or she was trained at the Breathe Institute by Dr. Zaghi," that's a green flag. Yes, do it. Go. If they were trained at the Alabama Tongue Tie Center by Richard Baxter, who's also written a book called Tongue Tied, Richard Baxter, anybody that has trained under them that would be where I would start. Now, I'm not saying that if there could be tongue tie specialists that do releases that are phenomenal and they weren't trained there. I'm just saying if you need those are two good names to remember: Dr. Sarus Zaghi, the Breathe Institute, or Dr. Richard Baxter, the Alabama Tongue Tie Center. And now I did a surgical residency under Dr. Zaghi, so I am an affiliate of the Breathe Institute. So they have affiliates. Those are doctors that have done a hands-on residency with Dr. Zaghi and have done a number. I did 20 tongue and lip releases with him by my side. And so that's where you really get some good training. And so I am an affiliate. The Breathe Institute also has ambassadors, and those are doctors who have completed a week-long course, a very thorough course and a very good course, and but they have not done their surgical residency. So I wouldn't say that, don't use one of them. There, that's a great place to start, and they most likely are doing a very good job. But that's the difference between an ambassador and an affiliate. If you go to an affiliate of the Breathe Institute, you know that doctor has done hands-on training in the surgical setting with Dr. Zaghi.
And I'll include this in the description as well. I know the Breathe Institute has a search engine on their site
Mm.
where you can search providers near you. Last I spoke to Dr. Baxter, they did not have a search engine. I think they said they were working on one, but they were very responsive. So you could always, if you don't find somebody through TBI, you could always message them on Instagram or email them, and they could probably give you some recommendations. So great. That's a great place, yeah, to start. So I think unless there's anything else, oh no, you know what? Let's do there were some questions that people had. Um oh, before we do that, I do want to ask what are some signs and symptoms that a parent can look for? And again, we're thinking specifically 4 years and up here,
Mm.
might indicate oral restrictions.
Uh, Great question. And it's really very simple. If your child rarely has his or her mouth closed, if they're constantly mouth breathing, there's a very good chance that they have a tongue tie. And the only way to mouth breathe is for your tongue to be at the bottom of your mouth, not up sealed in your palate. And if you have a tongue restriction, your tongue doesn't naturally go up there. And so you end up mouth breathing. And so that would be one thing that I would look for. Another thing, and you know, parents say, well, my child's running around the house laughing and, having a good time and they've got their mouth open then. That's not what I'm talking about. What's their mouth doing when they're watching a movie? What's their mouth doing when they're reading a book? What are they doing when they're sleeping? And parents say, well, I can't watch my child all night sleeping. No, but my recommendation, and we can talk about this later if we're talking about specifically, do they have a sleep disorder? But you want to look, you're not going to do a sleep test on a 4 or 5 year old. I mean, you can, but the best sleep study is for the parent to observe their child for 10 minutes every hour for 3 hours in a row and do that for about 4 or 5 nights in a row. So Monday, Tuesday, Wednesday, Thursday, make a commitment. I'm going to watch little Johnny from the time he goes to bed. I'm going to watch him for 10 minutes from 8 to 9, 10 minutes somewhere between 9 and 10, and 10 minutes between 10 and 11. I'm going to write down and record what I see. Is his or her mouth open? Do you see that? Maybe at 8 o'clock it was, at 9 o'clock it's not, at 10 o'clock it's open again. But you get 4 days of data over a period of you know you've been watching the child sleep for 30 minutes basically a night for 4 nights. You're going to get a really good idea. So that is how you can tell when they're sleeping. If is their mouth open or is their mouth closed and they're breathing very uh, gently through their nose. If their mouth is open, they most likely have a tongue restriction. Watch them when they eat. Is there do they or is it messy when they eat? Is food coming out? And I realize that little kids probably are going to be a little messier than adults are, but a 3 or 4 year old should be able to eat a meal and not have food coming out of their mouth. So watch that. Another thing, and Dr. Corridor just in, informed me of this the other day that she had read or was in a course. Have your child take a drink of water. When they swallow, do they close their eyes every time they swallow a drink of water? That's an indication that there's some oral incompetence going on as well. Just have them swallow water. Have them drink some water, hold it in their mouth, and say 1, 2, 3, swallow. It should look like you can't even tell. Maybe you see the throat move a little bit, but there shouldn't be any grimacing or, like something here, I'll take a sip. This is what it should not look like. something like that. That there's oral incompetence. Should look more like that, like you don't even notice it. So those are a few tests that you can just do on your child to maybe get a better understanding of what's going on. If you have your child lift their tongue up, everybody has a little frenum in there. Everybody has this little cord in there. Um, that doesn't mean you have a tongue tie. Everybody has that. If it's tied to the tip of the tongue and it's causing um, speech issues, yeah, that's pretty obvious. But most tongue ties are a little bit further back, and they can only really be recognized by what I just told you, those type of symptoms, and then a good clinical exam by a practitioner that knows what they're doing.
Yeah, I've heard people say, well, my child can stick their tongue out with any problem, so they don't have
Yeah,
a tongue. That's
and that's what a lot of physicians do.
yeah.
He can stick his tongue out, he's fine. That a lot of people with severe tongue ties can stick their tongue out. That's not the only test. There's a lot of other things that we look at.
So, is it possible, just due to the body learning to overcompensate, that there might be less obvious symptoms, and you don't have to get into those, but just kind of a yes or no? Is it possible for there to be oral restrictions and there not be some of these more obvious symptoms?
Yeah, there can be. I mean, all of us are good at compensating and might be hiding some of our flaws. And so yes, it could be every child, every person is different in how symptoms manifest themselves. So yes, I would say this. It's kind of like the Apple Watch now. They have a sleep apnea function on it. I was talking to Dr. Zaghi about it. He said if it diagnoses it with sleep apnea, you have sleep apnea. It's very, very accurate. But if it doesn't, that doesn't mean you don't have
Okay.
sleep apnea. So it's kind of like if your children have those symptoms I just told you about, yeah, there's a really good chance. If they don't, but they're still having trouble eating and they're having trouble sleeping, and maybe they have ADHD symptoms, maybe they're heavy breathing at night. Um, and you just have a parent's instinct is so good, then yes, get them checked because they can be camouflaging, not on purpose. I mean, they're not like, a 4-year-old's not saying, I've got a tongue tie, but I'm going to do this and that so mom doesn't think I have one. The body's just really beautiful at compensating for things, but that can also be detrimental as well because it might make something that really is not working correctly look like it might be working correctly, but eventually it will, it'll catch up to you. I mean, if you put a gallon of water in your gas tank every time you fill up, your car will run okay for a while, but eventually it's gonna,
Right.
it's gonna catch up with you.
Yeah, I asked that question to kind of make the point, and I think you'd probably agree with this. I'm kind of in the mindset of go ahead and find an airway dentist, pediatric airway dentist near you, and make them your primary, dentist, because a lot of them do your, typical cleanings and checkups as
Yeah,
well, and that way you're already established with somebody who knows what to look for
yeah,
versus waiting until you're scrambling to find somebody. That would just be my
right,
personal advice as a mom. But
yeah.
yeah.
And
uh,
on a word of caution, just because a dentist if they're a specialized pediatric dentist, they don't all really go into the airway realm. So you need to find an airway pediatric dentist, and that might not even be a board certified pediatric dentist. We see children for airway issues. We don't do pediatric dentistry. We don't do fillings and cleanings on kids, but we see
right,
them specifically for that. So I would you don't necessarily need to look for a pediatric dentist unless you want to, if you feel more comfortable with a pediatric dentist, find one that specializes in airway and jaw development too. If it doesn't matter, you just want to find a good practitioner. Make sure that if they do see children, that's what their bent is. It's jaw development, airway development, tongue and lip, and just overall oral competency development. It should be their focus.
and I would say you can usually tell a lot, at least on the surface, of a provider from their website, if they don't have anything about tongue and lip ties, airway, or if they do, but it's just very vague, I would maybe have some pause. I've at least found these providers that really know their stuff, they will provide you with a lot of information up front, a lot of times on their website, not always, but that's a good place to start. If you feel like they're really giving you some in depth information just from their website alone, might be worth looking into.
Yeah.
So we're almost done with the oral restriction section of this episode, but what are some of the consequences? Again, we're just kind of in the mindset of oral restrictions here. What are some of the consequences of not having oral restrictions released? And at the same time, what are the benefits of having them released early on?
Yeah. I would say the biggest long-term um, risk that you're taking, especially with a tongue tie, is that if you have a tongue tie that's restricting proper nasal breathing, then you are never going to breathe your nose properly, and you're going to be an obligate mouth breather rather than a nasal breather. And why is that important? Um, if you're a mouth breather, you're not going to die. What it is, it's a long-term quality of life issue. So let's say you're 5 years old and you're a mouth breather, and you have another 5 year old and they have plenty of room in their mouth, their nasal passages are wide open, and they breathe through their nose. They're obligate nasal breathers. Now, we can all breathe through our mouth if we want to intentionally, and that's fine. But long term, we want to be obligate nasal breathers. And so the one 5 year old, let's use the analogy that mouth breathes. That's the same thing as that 5 year old starting to eat every meal at a fast food restaurant, and sugary snacks and sugary drinks and lots of high trans fat food. Um, 20 years down the road, everything being equal, those two children are going to be, 25 years old. The other child is being given organic grown vegetables and, maybe an occasional sweet, you cookie or something like that. But for the most part, they're eating, just as healthy, down to the earth as we can get. Fresh vegetables, fresh meats, pasteurized, uh, uh, organic beef and chicken. They're both going to survive. They're both going to live, but only one of them is going to thrive. So the long term consequence of having a tongue tie could be, and most likely will be, um, a patient that through their life is going to be subject to chronic diseases that an obligate nasal breather will not be. So your chances, if you're a nasal breather, you're going to sleep better. You have a much better chance of having good quality sleep every single night. And if that's the case, if you breathe through your nose and have good quality sleep and you maintain, a healthy lifestyle, you don't have to be an Olympic athlete, but just a healthy lifestyle, the chances of you having a chronic disease like atherosclerosis, diabetes, heart disease, those are going to be minimal. Cancer, your chances of getting cancer are much, much less. If you're mouth breathing and you have poor sleep, your chances of getting any and or all of those chronic diseases increase dramatically. So this is a question about quality of life and longevity, more than it is about an immediate result. But without proper sleep and without proper breathing, even the even the healthiest diet and exercise in the world will not compensate for not sleeping well and not breathing well. And many, many people, the majority of kids that I see that have issues sleeping, they have some oral incompetence, and it's usually associated with a tongue tie or a tongue and lip ties.
Can you give some encouragement to moms? I just know as a mom, if this was all new to me and I'm hearing this, there could be some out there that are going, well, my child had a tongue and lip release
Yeah.
however long ago, and they didn't mention anything about myofunctional therapy or body work. We didn't do any of that. Or maybe they're thinking, well, my child is 16 now and they have all of these symptoms. We haven't done anything, to
Right.
give some encouragement to parents that might be in that boat of,
Yeah.
the world, there's still hope.
Yes, and that's exactly, I was just gonna say that. That is the theme of our practice. When we have morning meetings, our goal is everybody that comes in that office looking for answers, we give them hope. And we're very honest with them and where they are, but we give them hope because what I would say to that parent is it's never too late. Or if if you're a parent, but your children are grown in a way and you're maybe thinking about yourself, it's never too late. We have 70-plus-year-olds, 70 and older in airway development devices, and it makes a difference in their life. So it's never ever too old. It's kind of like smoking. It's never too it's never you're never beyond the point where quitting won't help you. If you've been smoking for 50 years and you quit, you're going to get healthier. So my answer would be you're never too old. It's always There's always a starting place. The but a accurate diagnosis needs to be made, and then treatment options based upon what you want for your child or for yourself need to be discussed, and the game plan needs to be set up and then followed, and you'll see a different child whether they're 5 years old now or whether they're 25 years old now. You're going to see a different person in a year, 2 years down the road, because it's never too late to start nasal breathing. It's never too late to stop poor sleep and start good quality sleep.
Awesome. Okay, before we head into the sleep disorder portion, there was one question that I got on Instagram multiple times, so I wanted to just ask that.
Okay.
Uh, how or when, if there is a diagnosed oral restriction, when or at what age should that child get released? I mean, if it's diagnosed by a quality,
Mm,
provider that knows what they're talking about at 6 weeks old,
yeah.
is that too early to have a release done?
No. No, not at all. If it's diagnosed and it's causing a detriment to that child's health, it needs to be done. Now, of course, a 6-week old is not going to go through myofunctional therapy, but I would tell the parent if they do have a release, their IBCLC should be able to give them some um, stretching exercises and things that they can be doing to ensure that the release, if done properly, takes, and that the child will be good. Now, that doesn't mean that they won't need another revision later down the road when they can have proper myofunctional therapy and everything. But if you have a restriction that's causing a detriment to the child, then it needs to be addressed then. So I know Dr. Zaghi from the Breathe Institute, their first child was 3 days old when he had his lip release, or I'm sorry, had his tongue release. So, you don't get much younger than that.
Yeah. Well, and maybe it depends on the child. I would almost say maybe the younger, the easier.
Yeah, they
Again,
won't remember it. It's
every,
not
yeah,
it's not a traumatic thing at all. As a matter of fact, a lot of the time, most of the time, you have a child that if they have really severe nursing issues, um, the release is done and the child is immediately given to the mother, and they latch, and the screaming, crying that you heard for 30 seconds is completely gone. They're happy as they can be.
yeah. For some encouragement out there, my youngest, I think she was probably about 10 weeks old. And through seeing an IBCLC and a craniosacral therapist alone, I saw tremendous improvement. Um, but after the release, the last kind of piece of the puzzle was she was still clicking. I could tell a lot of the tension was gone and she was nursing better, but there was still some clicking. And the second, I mean, they did the release. brought her back to me. I nursed immediately, and the clicking was gone immediately. And the recovery, we had to do the stretches, which, is annoying, but it wasn't horrible. And the recovery was so easy. I mean, again, every child's situation is going to be different, but at least for us, I mean, we didn't even hardly have to use I think they gave like arnica or something. We didn't even have to use that. Um,
And in Europe, I don't know if you've ever mentioned this in any of your podcasts, Alex, but in Europe, it is required when a child's born in a hospital for a tongue tie or lip ties to be uh, addressed or to be evaluated. And if they have one, they do it immediately. And in the United States, that is not the case. So there are so many areas in the medical profession that we are superior to anywhere else in the world, but there's other areas where we're lagging way behind.
I will say, yeah, and I know Brazil is they're very far advanced in their knowledge of oral
Yeah,
restrictions.
yeah.
I will point out some hospitals here in the States will check for a oral restriction. I don't think they'll release them, but I would hesitate to take whatever, the practitioner at the hospital is saying as gospel, because that did happen with Miles. The
Yeah,
pediatrician at the hospital was like, oh,
right.
no, he's fine, whereas all these other people were saying different. So
Yeah.
as
Well, let me clear in Europe, they don't, I mean, it's still the parents' decision. They don't say, your child has a tongue tie, we must release it against your wishes. It's still, they are, every hospital in Europe does that. They evaluate that on a newborn. And I think that's great.
Okay, so let's move into the sleep disorder portion. Restricted airways and therefore sleep disorders seem to be pretty common nowadays, or maybe it's just that we're hearing more about it. Why do you think this is the case?
I think it's we know more about it now, so we know they've been there for years. So if I may take a just kind of a side road on anthropology, really what we know about restricted airways and small jaws and how that relates to sleep, we really need to thank our anthropologists for that. Dr. Corricini is probably leading the way in that. He's an Italian anthropologist that basically specializes in facial development. And he found that before the Industrial Revolution, which was about 300 years ago, there were relatively few accounts of skulls with small jaws. All the jaws were perfectly formed with 32 teeth. And we tend to think of people that lived hundreds of years ago had really scraggly, gnarly teeth, but they really didn't. They had beautiful teeth because they were eating from the earth. They were eating. They didn't have processed food, no processed sugar. Then the Industrial Revolution came along, and literally our biome, our genetic wiring, we were eating the same way for thousands and thousands of years. And then in an instant on that timeline, food supply changed to processed foods, literally overnight. And our bodies aren't equipped to deal with that. And so from the Industrial Revolution to modern day, our jaw sizes, ours meaning humans, Homo sapiens, our jaw sizes have gotten smaller every single generation. So it wasn't until a couple of hundred years ago that the orthodontic profession even began because there was no need for it. So we started seeing jaws that were smaller and teeth that were crowded. And you saw no crowding of teeth before the Industrial Revolution to speak of. The only areas you saw that in were royalty, and they had their food processed for them. They could afford to have food cooked to just the delicacy profession, whereas the working class out in the fields, they were killing a deer and cutting it up and cooking it the best they could and then chewing on it, and their children were eating carrots and broccoli and pulling roots out of the ground and eating nuts, and from the time they had two little teeth in their mouth. And that's the only way that bones can develop, if there's muscle activity going around them. So if you look at the health of a bone of a bodybuilder, say a bicep, versus the health of a bone of someone that lifts no weights at all, the bodybuilder's bones are going to be bigger and stronger and they're going to be developed better. So as we develop muscle, muscle activity develops bone. The maxilla, this upper jaw, is the only bone in the body really that doesn't get a natural workout. You know, we have to lift things with our arms and we have to walk with our legs and we have to bend over with our back. And so those muscles are constantly getting worked. But if all we're doing is chewing, you know, eating, look at the baby aisle in the grocery store. Everything is soft, pureed. There's nothing that's chewy. And so we really talk to our moms and dads about, hey, start getting your children chewing on things at an early age. That's how the jaws develop. So going back to that, people have their jaws have gotten smaller, humans, for the past, what are we, about 8 generations now from the Industrial Revolution, and they're just getting smaller every generation. And so the floor of the mouth, I'm sorry, the roof of the mouth, the hard palate, it's the same bone that's the floor of the nasal passages above it. So if this maxilla develops very narrow with a high palate because we're not chewing and crunching and things like that, the nasal passages then are smaller and it's harder to breathe through our nose. So we're more susceptible to congestion. We're more susceptible to nasal restrictions. We're more susceptible to deviated septums because the 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 if the higher the palate is, the shorter the distance for the nasal passage is, and so we see a lot of deviated septums that we didn't see before the Industrial Revolution. There were very limited accounts of deviated septums through anthropological studies of skulls. And so if you can't breathe well through your nose because it's restricted, you're going to breathe through your mouth. And if you breathe through your mouth, you're not getting nitric oxide in your air. You're not getting warm air flow that you get when you breathe through your nose. The air is not filtered when you breathe through your mouth. So you're just breathing in all kinds of toxins that would otherwise be filtered out through your nose. And again, going back to the nitric oxide is a vasodilator, so it opens up the blood vessels in the lung and you absorb more oxygen. So nasal breathing is deep breathing. It has a calming effect, whereas mouth breathing is very shallow. And so we see kids that have chronic asthma, they're mouth breathers. They've never used the bottom half of their lungs. They're just using the top half. So the bottom half just kind of they're it just sits there and doesn't get used. And that's where asthma can come from. I'm not saying every kid that has asthma, that's the case, but it's a pretty darn high percentage. So, um, skull development, specifically the upper jaw, has been really the center point of why we now have more, why we have sleep related breathing disorders that didn't exist 300-400 years ago.
Yeah, no, definitely. And I know I'll point out, I think that a lot of parents gravitate towards these, purees and mashed foods. Number one, because that is a lot of times just recommended, unfortunately. But I also think there is this fear of their child choking. And so,
Yeah.
just for some encouragement, there is a way to safely baby led wean your child, and safely introduce pretty much any food out there starting at
Yeah.
about 6 months. There's a great app called Solid Starts, and you can search any food and it shows you visual examples of how to properly cut and prepare that food for that age. And I think it's at 6 months. Don't take my word for this. If you guys are listening, download the app, double check for yourself. But if you look up steak, I believe at 6 months, the recommendation is to serve them a large strip of like a tough meat for them to just chew on. Because at 6 months, they're not going to be able to actually take a bite big enough out of it to choke on it, but they can chew on it, get the flavor, work their jaw muscles. We did that with Evelyn. She loved it. There was no way that she was going to be able to get a chunk off to choke on.
Uh-huh.
Obviously, keep an eye on your child, but there is a way to safely introduce these foods. And I am just saying this for my own personal thought. Maybe there's science to back it up, but I feel like the younger you introduce these foods, the less likely they are to choke in the future because
Yeah.
from an early age they are learning what the proper bite size is, how to properly chew to safely eat.
That's so true. The reason kids choke on things is because they weren't trained to chew properly, and and they get something in their mouth they don't know what to do with. So the tongue, instead of working like this, works like a conveyor belt, and it just conveys the food till it drops down into the airway. So it's like, you see these kids when you go snow skiing. They're 4 years old and they're just blowing by me, but they were their parents put them on skis when they were two and a half, and so it's just natural. So I can't I just remember the envision of Evelyn. You sent me the picture of her with this, it looked like a huge piece of steak compared to her little head, but she was just gnawing on that. She was in heaven. So yeah, things like that. It's so it's so simple that it's almost unbelievable, but that is the case. Why otherwise? Why would our jaw sizes from 2025 be 25% smaller than they were, in the 1700s? It doesn't make sense, other than what the one thing that's changed is our diet. And also there's more pollution now, so people get their noses get clogged up and they have to breathe through their mouths more. So there's more chemicals in our environment now. So there are things that we can control. There's certain things that are out of our control, but what you put in your child's mouth is completely 100% in your control. It does take some effort, it takes some work, but believe me, those pureed foods at the grocery store are bad news. In a spot where you just need to get something in your child, fine, but overall they should be chewing their food. And I think the source that Alex gave earlier, I'm sure she'll put that in the down at the
Yeah.
bottom. But that's a great book. She showed it to me before, and
Yeah.
it really goes through pretty much any and every food your child might be eating, and how to cut it up and how to prepare it.
Yeah. And there's no shame. I want to add, there's no shame if you're serving, well, we won't get into the ingredient side of things, but just from a texture standpoint, if you're serving chicken nuggets and waffles or meatballs or cheese sticks and pouches, these are all things that Miles loves. We serve all of those things. You know, I don't think that you need to say never and again are we buying or serving these things and whatever, there can be a time and a place, but I always try to make sure like, okay, well maybe we're having, a protein waffle for lunch. I'm also going to give him a whole apple. He loves, munching on whole apples, or, maybe I'm going to give him a chunk of steak as well. I think that there can be a balance there. I don't want parents to hear this and say, well, there goes my life. I'm throwing out all of these things. It's all about balance, and just make sure that you are, making time for these foods that really help, exercise the job.
And the Myo Munchies, I'm sure you've talked about those in your different social platforms. So Myo Munchies are great. They're you don't eat them, but they're just an exercise tool for the children to chew on. So
I'll link
um,
that
you know,
as well.
there's a lot of products out there that are geared towards helping develop
Yeah.
the oral structures.
I'll link that, and then there's another thing. This is I think more 3 years and up. The Myo Nozzle, which is
Mhm.
a device you put on the tip of your straw. I'll put that down in the bottom as well for people to check out. So, what are some signs and symptoms? We kind of covered this with the oral restrictions, but just again, what are some sort of clear signs and symptoms that a child could be suffering from a restricted airway
Yeah,
or sleep disorder?
I always tell my parents, think of Dairy Queen Sunday, DQS, dry, quiet, and still. So when a child sleeps, we don't want them drooling, wetting the bed, night sweats. If they have one or two or all three of those, that's a sign. Um, so we want their sleep to be dry, quiet. You should not be able to hear them breathe. Okay, should be like the example I use. If you go up into the mountains of Colorado and you're by a river, it's going to be roaring and it's going to sound beautiful, and you're going to see all the white water, and it's great. That's not what you want to hear from your coming from your child's mouth or nose or body when they sleep. It's like being next to the Mississippi River, just nice and slow and quiet. That's what we want to hear. We don't want to see their thorax um, extending because they're trying to get air. We just want to see a nice level breathing that you can't hear. So that's the cue, quiet. And then still, we don't expect a child or a adult to stay in the same exact position all night, although some do. But we also don't want their sheets to look like a helicopter was turned upside down and messed them all up. So they want to be relatively still during the night. A position change every now and then, no issues with that. So how do you know if they're doing that? Again, you can record them all night if you want with the, with the uh, cameras that we have now. That you could do that if you want, or you could do, as I said earlier, go in for 10 minutes at a time and just watch them for 3 hours in a row, and do that for 3 or 4 or 5 nights in a row, and look and see, do you hear them? Are they moving around a lot? Are they drooling? Are they wetting the bed? Do they have night sweats? Night terrors as well. A night terror is more than a night terror is more than a nightmare. A night terror is that the child actually is acting it out and they're thrashing around. So that though, if they're having night terrors, there's some sleep related breathing disorder going on. So those are three things that you can look for visually when your child's sleeping. Other things, do they have excessive daytime sleepiness and fatigue? Do they hop out of bed in the morning and they're ready to go, or does it take forever to get them up, and it takes 30 45 minutes to get them going? When they take a nap, just watching, or do they need to take naps? Now I realize little children need naps, they need more sleep than adults do, but if you have a teenager and they're constantly falling asleep, that's not good. um, so they don't feel refreshed when they wake up. If they get up a lot at night, that would go under the still category. They're not being still. We're waking up a lot and they're getting out of bed. Um, if they have difficulty falling asleep, that could be a sign that they're not getting good sleep, and it's difficulty falling asleep. Um, of course, cognitive impairment. There are other things that can cause cognitive impairment, but mood swings and irritability are things that you can look for too, and depressive symptoms and high anxiety. So many of the kids that have high anxiety are kids that just can't breathe, and so my um, my caution to parents is, if with older kids, if they have a sleep test and they're not diagnosed with sleep apnea, then that doesn't mean they're okay, because and there's another condition that affects many more people than those that suffer from sleep apnea, and it's called upper airway resistance syndrome, or UARS. All of those symptoms that I just told you about are symptoms of both sleep apnea and upper airway resistance syndrome. The difference between sleep apnea and UARS is that in a sleep apnea patient, the sleep test actually diagnoses them by the fact that they quit breathing for 10 seconds or more, 5 or more times per hour. Okay. So that in itself can have a physical debilitating effect over a long period of time, because when you can't breathe, your thoracic pressure builds up and it can have an effect on your internal organs. So I've had some patients that had an AHI, which is the apneic hypopneic index, of over 100, where 100 times per hour they would stop breathing 10 times or more. That's a mortality risk every time you go to sleep. At the bottom of that, a mild sleep apnea, maybe they're just doing it 6 or 7 or 8 times an hour, but the symptoms are exactly the same. Maybe they have no sleep apnea, but they have respiratory disturbances, what we call RDIs, respiratory disturbance index, of 10 or 20 or 30 times per hour. So they don't stop breathing, but their breathing is interrupted. Their sleep cycle is interrupted. The point I'm making is the symptoms are exactly the same as if they had sleep apnea. So for a child, go back to the Dairy Queen Sunday, and if you see any of those happening, and that's coupled with, you know, daytime sleepiness, um, behavioral problems at school, inability to concentrate, depression, high anxiety, all those daytime symptoms could very well be related to the fact of what's happening at night when they're sleeping. So rather than going in and getting diagnosed with ADHD, which a lot of these kids would, I would go through the sleep um, route first, because you might see many, if not all of these symptoms go away. Which I'll just go ahead. Alex and I were talking about a great study done by Dr. Karen Bonuck, Bonuck, back about 10 years ago, that involved 11,000 children. And Alexandra is going to put a link in at the bottom of the page, probably around this time, so you can go and watch this YouTube video. But basically, what they did is they took 11,000 kids. Many had been diagnosed with ADHD. Many had been diagnosed with sleep-related breathing disorder, and they observed them over I think, a 5 or 6 year period. 11,000 children, and from the ages of, I think, 6 months to 7 years old. A significant study, and it showed that they all had exactly the same symptoms. And the great part about it for the kids with with the sleep disorder is they were treated by all the things we talked about: myofunctional therapy, oral expansion to open up their airways. Those children got significantly better. Their symptoms went away. Their grades improved and elevated. Their behavioral problems went away. Um, while many of the ADHD kids who had the same symptoms, they're treated with medications. And so what we want to do is we want to try to eliminate as many of these medications for these kids as possible. So I'm not a medical doctor. Um, I'm a dentist who specializes in airway health, but I will tell you this: if your child has been diagnosed with ADHD, I would get them, whether they're on medication or not, get them to an airway dentist and an airway specialist, and have their sleep evaluated and get them breathing and sleeping well. And hopefully, and I think the vast majority of these kids will improve and not need medications for the rest of their life. That's my opinion. That's one doctor's opinion. So I'm not giving any medical advice here, but I would do that.
Yeah, I agree. Um, this might be a bit of a broad question, but what is the typical treatment? Let's say a child has been diagnosed by an airway provider with a sleep disorder, upper airway resistance syndrome. What is the typical treatment, and how young can it start?
Yeah. Um, any treatment can start at any age. So, first of all, there are things you can do at home starting. If you're listening to this podcast, you can start it today. Um, Blue light filters. Have your child wear blue light filters when the sun goes down. Our brains have a little gland right in the middle called a pineal gland, pineal. And that pineal gland is responsible for sensing their circadian rhythm. And so back, 500 years ago, when gas lamps were probably first invented, and so people it would get dark and they would turn the gas lamps on. Well, we all know gas lamps are nice yellow light. They're not full of this blue light that we have now with, inside our houses. So before gas lamps, it was a fire. You know, the there would be a fire made. Um, but the pineal gland can then sense that the sun is setting, the light is going down. There's still some yellow light, but the light's going down. It starts releasing melatonin at the correct time. Melatonin is a sleep aid, among other things, is a very valuable um, chemical that's released in our body naturally. If now in our modern society we've got kids that are on screens, they're on iPads, they're watching television. um, so we have blue light filters that can be worn, and when the sun starts to go down at night and it's still light inside of our house, this then tells the pineal gland that, hey, the sun's setting. It filters out all the blue light. It allows the pineal gland to do what it's supposed to do. That's one thing that you can do. Create the ideal sleep environment. Ideally, you want white noise, brown noise. There's all these different colors of noises, and they all have a different effect. But any of these they're all intended to create a calming effect. So I know the white noise makers, and Alexander probably has different brands. We have a whole sheet we give our patients. On one side, it has sleep hygiene, what I'm telling you now, and on the other side, it has all the products that we recommend. And Alex has that as well. But white noise, filter out any light in the room. You want the room really dark. You don't want light from a mercury vapor lamp of street posts, street light coming through the window. So you want to keep that environment very quiet, very dark, and you want to turn the temperature down to 68 degrees. That's the ideal sleeping temperature. And so those are some things that you can do immediately. You can, obviously, this goes without saying, but for adults, stop drinking caffeine at night. Don't drink alcohol at night. Alcohol has a sedative effect, but once it's been in your system for a couple of hours, it might make you groggy, but then the liver has to metabolize the alcohol, and it creates a lot of heat in the body. And people wake up sweating. They sleep restlessly when they're trying to metabolize alcohol. So on a nightly, regular basis, I would caffeine has a half-life. I'm speaking strictly to adults now. Caffeine has a half-life of 12 hours. So if you have 2 cups of coffee at 10 o'clock in the morning, half of that caffeine is still in your body at 10 p.m. So just keep that in mind. And then, of course, alcohol. We want to, on a regular basis, we want to, not have any alcohol to drink for at least 4 or 5 hours before you go to bed. If you have a calcified pineal gland, which can be diagnosed from a cone beam computed tomography X-ray, that's what the 3D X-rays that we take in our office. We can see if the pineal gland has been calcified. Then perhaps your melatonin output's not as good as it should be. So melatonin supplements can be taken. The problem is most people take them too late. They take like right before they're going to go to bed, and then the melatonin's peaking about the time it should be, getting less. So I have my patients that do take melatonin supplements to take them about 3 hours before they go to bed, and then the melatonin peaks at the right time. So,
Can I ask a
but
question
mhm,
about that? Obviously, if the pineal gland is calcified, that's a whole different situation. But for somebody where that's not the case, and because I think a lot of times people, when they don't know, they just think, oh, I'm having trouble sleeping, I'm just going to take melatonin every
yeah,
night.
yeah,
There, um,
yeah, and it's not like taking a pharmaceutical drug, something like that. But you shouldn't have to take it, but if you do, just take it like 3 hours before you go to bed. So another thing, wearing the blue filter lights, if you do those on a regular basis, it will reprogram your melatonin output, because the pineal gland will start thinking, hey, sun's going down, because it really is going down. You're just masking all the blue light inside your house by using blue light filters. And you can still watch TV and read and everything. Yeah, it affects the color a little bit, but you know, you can still do everything that you would do. Another thing that this might sound crazy, but it works. You need to find out what time sunset is, what time sunrise is, and be out during that time, preferably grounding on in your bare feet three about at least 3 minutes during that time. So let's say sunrise at 6:38 tomorrow morning. I can look on my Apple Watch and see. So I would walk out my front door or my back door, and obviously in the winter, probably not going to be in your bare feet, but in the spring or summer, and I'm going to just walk around in the grass for about 3 minutes from 6:37 to 6:40, um, and then do the same thing in the evening for sunset. So sunsets 7:15. Make sure you're outside, and you don't have to be looking at the sun. You just want to be out in that environment. And if you will do that for 1 month, every single day, you'll see a difference in the way you sleep. So I know it sounds crazy, but it
At all.
works. Mhm.
Okay.
Sometimes solutions are so simple they don't seem like they're a solution.
Yeah. Um, Really quick, because I do want to ask for my own curiosity, going back to melatonin. From my understanding, and again, you're the clinician, so you can correct me on this. Is it possible that if somebody is taking melatonin nightly, long term, that it could um, inhibit the body's natural production because the body is recognizing the intake of the
Yeah,
melatonin and then thinks, okay, well, I don't need to produce
right.
however much because
Yes, that's a good question, and you're exactly right. So I would use those techniques I uh, said earlier, and maybe start reducing the amount of melatonin you take, and then just slightly wean yourself off of it. And while you're doing these grounding exercises and the blue filter glasses and the sunrise, sunset outdoor activity, and then at the same time start maybe taking half the melatonin for a week, and then maybe a fourth for a week, and then quit taking it. See what happens.
okay.
Yeah, I would
Um,
recommend that. I never like taking something that the body produces naturally. If it's able to produce it, let the body produce it.
yeah. I tell people, and please tell me if I'm wrong, if I'm wrong, that if they are dead set on no, I want to take something, I'm going to take melatonin. Um, I always suggest, well, okay, before if this is what you're dead set on, before go that route, maybe try magnesium first. And
Yeah.
I just because I know many people are magnesium deficient, and I just know from personal experience, Leah, my husband,
Mhm.
has seen major
Yeah.
improvement in his sleep just from magnesium alone.
Yeah, I'm glad you brought that up because actually I was going to say something about that earlier and I got sidetracked and didn't. But I would, if someone said I want to try one or the other, I would do magnesium because, like you said, we're we are generally low on that anyway. So I would do the magnesium, and that's not something that you have to take. You know, you can take that right at bedtime if you want to. I'd take it maybe an hour before, but I would try magnesium before I would do
I'm looking
melatonin.
it up just to make sure because I did a magnesium guide with a nutritionist. There's all sorts of different forms of magnesium. They're all great, but I know specifically for sleep, I believe it's magnesium glycinate that is
Yeah,
typically recommended.
you're right. It's a magnesium glycinate, and usually any of the brands you would see maybe at Sprouts or something like that are going to be good. I would look them up. I would do some research and find the ones that are the highest rated. I
I'll
know Alexandra gives resources on places to go that research these things out, and you can find products that are rated. So
I'll include my magnesium guide in the description because I did that with a natural nutritionist and she gave specific recommendations on which forms are best absorbed, and there's
yeah,
specific recommendations in there. Okay, so you talked about things that people can be doing at home starting today. let's say a child does need to move into more of a clinical treatment, what does that typically look like? And what age do those more clinical treatments start?
So in our clinic, we and we don't have a cookie cutter approach, but we do have some guidelines. If we have a child that's younger than 8 years old and they're having some sleep related breathing disorder symptoms, and we look in there and we see that the dental arches are not, uh, they're a little bit or even severely underdeveloped, and maybe we're looking at the tonsils and they're, because the patient's mouth breathing, they got these really swollen tonsils. um, we typically will start a child like that with a growth guide, and growth guides are specifically um, given to a child based on the measurements of that child's jaw. And they're basically a um, semi-hard rubber, or I guess you could say semi-soft, however you want to look at it, appliance that goes in the child's mouth that promotes nasal breathing, that promotes, helps guide the teeth as they come in, and they actually kind of clench on it, and it helps develop the bones, and so the development of the maxilla begins if it's been deficient. We also would have them see an ENT if they've got swollen tonsils and congestion. Um, we encourage food sensitivity testing, because many times these kids will have swollen tonsils because they're allergic to dairy, or they're not even necessarily allergic, but they're sensitive to dairy products or maybe corn products. And so what we're trying to do is get the airway as patent as possible. And if the child is ingesting something that's just detrimental to what we're trying to do, we need to know that. So we do food testing, sensitivity. We recommend mold testing, having the house tested for mold, having the child tested for mold, allergy testing. Um, and that's for a child that's maybe under 8 years old. We generally want to try something very conservative like a growth guide first. And basically, these growth guides, it's like a super modified, I don't even want to, but like a pass. I mean, it's like a mouthpiece. So you see these athletes wear these mouthpieces in their mouth, but they've got different functions built into them that promote jaw growth and nasal breathing. If they're over 8 years old, we'll usually start that patient into some sort of fixed expander. Um, some children, we can do removable expanders. We leave that up to the parent. If no one knows their child better than their parents. So if we say, look, we can do a removable expander, but it's got to stay in the mouth all the time, but they can take it out to eat and to floss and brush. Oh yes, Susie will do that for sure. Bobby, no way. We're going to have to do a fixed expander on him. Parents just know that. So we start some type of expansion device at that point. Um, and what we typically see from the orthodontics in my area, and the orthodontic therapies that I see as I lecture around the country and the world, but especially in the United States, the typical orthodontic approach is to do about 3 months of expansion at age 7 or 8, and then just hold the patient until they're 12 or 13, and then they have braces placed on. We look at that age from 7 or 8 to 13 as a prime time for us to be growing the maxilla, which will often negate the need for orthodontics or make the orthodontic uh, case uh, much less extensive and much easier. So that period, when a child is growing up to 12, 13 years old, is the prime time to develop the jaw. And a typical 4-year-old should have a 30 millimeters between their baby molars. And if it's less than 30 millimeters, we know that child is underdeveloped. A 12-year-old should have about 36 or 37 millimeters between their 6-year molars. An 18-year-old should be, if they're developing properly, are going to have over 40 millimeters of intermolar width between first molar to first molar. So that's a general guide that we look at. If I see an 8-year-old, we basically add 24 plus their age, and that's the size of their jaw. Should be minimally. So if I see an 8-year-old, their 6-year molars are in. If I measure between the 6-year molars, an 8-year-old should be 32 millimeters or more. Okay, if they're 30, 28, 29, they're behind. So what if we get an 8-year-old that's exactly 32, 24 millimeters, or 24 plus 8 is 32, but they're having all kinds of symptoms. So for someone like that, for a child like that, we of course we're going to identify if they have tongue, tie or lip ties. We may start a child like that on myofunctional therapy and then do a tongue and lip release and see where they are in 6 months. That might be all they need. And the best orthodontic or the worst orthodontic appliance is your tongue. It's either going to work for you or against you. So if we have a child that's right in that area, about where they should be, but maybe a little bit behind, we do everything we can to let the body's natural process develop the dental arch and develop the airway. And we don't intervene right at first. But if they're 2 or 3 or 4 millimeters behind, we're going to go ahead and get them an expander and get them where they need to be, and then take the expander out, myofunctional therapy, do the tongue, lip releases, and then let their body, then we just observe them. And, we observe them every 6 months and see where they are. Because our goal is to bring a child developmentally where they need to be for their age. And, if the expander takes them a little bit bigger than they need to be, great. That's awesome. So if we have an 8-year-old that's 4 millimeters behind, so they're supposed to be at 32 millimeters intermolar width, and we expand them to 32, but we've still got 2 or 3 millimeters left with the expander, we're going to go ahead and get that. You can't get too much. So, but then we're going to take the expander out. We're going to put them in a retaining device, which is just a little wire that goes across the palate, and it just holds everything in place, very non-obtrusive. And they start myofunctional therapy, and then we evaluate them again in 6 months and a year. And hopefully, what we see with all of the other things we've taught mom and dad about their diet, about how they should be breathing exercises, about all the stuff we've talked about, we just give the patients as much ammunition as we can, as much information as we can, and our goal is to get that patient where they need to be, maybe even a little bit more, and then have the body's natural, the tongue's natural function take over from there and everything develop naturally. Um, if they're way behind, then obviously we can catch them up where they need to be, wherever they are. So it's just the younger we see children, the faster we can get them where they need to be, and the faster they can start breathing correctly and functioning correctly.
So before we move into some of the questions that some people asked on Instagram, I do want to spend a little bit of time on sleep disorders and ADHD, because I think that this is very prevalent and a lot of talk about this on the internet. So I feel like, and I was a teacher for a hot minute and saw this firsthand, a huge prevalence of ADHD diagnosis. And because I had worked for you and still work for you, I knew probably more than the average person of what to look for. And so I would have all these students on 504 plans because of ADHD, and they're on medication and whatever. And I could tell just from looking at them, they are not sleeping well. So
Yeah.
how can a sleep disorder mimic ADHD symptoms or lead to a misdiagnosis of ADHD?
Yeah. Well, ADHD is simply a, a conglomeration of symptoms that if a child has, they're ADHD. So they can have a sleep related breathing disorder and have an accurate diagnosis of ADHD. But the thing with ADHD, it's just diagnosed and treated. It's never the cause of ADHD has never been, as far as I know, there's never been a medical um, article written, and I may be completely wrong about, other than what we're talking about in airway dentistry. of the cause of ADHD. So sleep related breathing disorder, um, symptoms. So let's say a child goes to sleep every night and they can't breathe well. Okay, so the body, the brain, while the brain is sleeping, it's going through its cycles. And by the way, when a child is growing, they grow while they sleep. If they don't have poor sleep, they're going to be underdeveloped, not just in their jaw, but their whole body. They're not going to grow properly. That's when growth hormones released. But if the child's sleeping and they're struggling breathing, they're going to have carbon dioxide buildup in their body, and the brain doesn't know if this patient is snoring or just has a restricted airway or if there's someone choking them. So the brain sees it as, oh my gosh, I need to get out of this deep sleep and go into a lighter sleep where my jaw then will open up and my muscles will start contracting again. Because when we go into REM sleep, that deep sleep is, or the REM sleep, our muscles go into paralysis. And that's where we're really subject to the jaw dropping back, and we have that, and the airway gets cut off. And so but there's a reason for REM sleep. It's part of the natural cycle of our sleep pattern every night. Just like when you shut your computer down, you go through, you don't just turn it off. You go to a shutdown, and that shuts down your computer in a systematic manner, so that when you open it back up, it opens up in a systematic manner. So think of sleep cycles as shutting down a computer and rebooting it. That needs to be There needs to be a proper sleep cycle on all night, and we know what those sleep cycles are. So when we do a sleep test on somebody, we can look at their sleep cycle and see all of this irregularity. So bottom line is, you're not sleeping well. So if someone were choking you or put a pillow over your face, you would immediately go into a sympathetic nervous system state, or what we call fight or flight. It's the same response you would get if you walked into your house and there was a grizzly bear in your living room and it raised up and roared at you. You would get out of there really quick, fight or flight. Parasympathetic is calm. That's what we should be in when we're sleeping. But if we're not getting proper sleep, then we're going to be in a fight or flight, but not only when we're sleeping, but during the rest of the day. So we're very anxious because we didn't get good sleep. Our brain's going 90 to nothing, trying to stay awake. Um, Most ADD, ADHD kids, if you make them stay still and put them in a nice cold room at 1 o'clock in the afternoon with a little blanket, they would be out like that. But they're treated with Adderall or these other type of drugs, which just overstimulates everything and it calms them down. So yeah, it does have an effect, but it's an amphetamine. So sadly, we see kids that are 8 years old that are taking amphetamines, and if they don't have the proper or if they don't have, okay, they've been diagnosed with ADHD, but the parents have never been told why they have ADHD. There's even some books being written now which this really scares me, about ADHD as a gift. You should embrace your ADHD, because ADHD kids are brilliant and they can do this. Well, you know what? If a child is brilliant and you take their ADHD away from them, they're still going to be brilliant.
Yeah.
So the ADHD, to me, is I'm not saying, I'm not going to go into any conspiracy theories here, but it's not being treated properly, in my opinion, because if I took 100 kids with ADHD and I diagnosed them, most of them are going to be diagnosed with a sleep related breathing disorder, if not all of them. And if I treated those symptoms, or if I treated that breathing disorder, there's going to be a vast majority of them that their symptoms go away completely. And I would go as far as to say is all of them are going to get some benefit from a non-medicine, non-pharmaceutical treatment by just helping them sleep and breathe better.
Yeah.
So even if it didn't go away, even if I diagnosed them with a sleep related breathing disorder and we treated that and they're sleeping beautifully now and they're still having some of the symptoms of ADHD, we at least know they're sleeping well and they're going to develop well. So to me, it's a no-brainer when you're looking for solutions for your children that you go that route first. Or if you're already on the pharmaceutical route, have them uh, seen by an airway dentist and have them evaluated. And if there's an issue there, have it treated and
Yeah.
and see what happens. I think you'll be very, very pleased.
Yeah, I'll before we move into some of the questions, I'll point out to the American Academy of Pediatric Dentistry and their official recommendations. They acknowledge that there is a huge prevalence of incorrect ADHD diagnoses due to sleep breathing disorders. So I would
You
say it's
you remember, Alex, when I interviewed Dr. Sachs,
not
he
Dr.
was telling, pardon?
I'm just for people listening, Dr. Leonard Sachs. He's
Yeah.
a family physician and a psychologist. He's phenomenal. But yes,
Yeah, he's great. I actually saw Megan Kelly was interviewing him a couple of months ago. But it was a great interview. But I'll never forget, well, a lot of the things he said. But he would ask parents, "Do your kids get sleep?" "Oh yeah, and these are more teenagers they're talking about here, but could be for kids that are 8 or 9 years old, just depending on their home environment. But parents would say, "Oh yeah, they go to bed at 10," and you'd say, "Well, when do they go to sleep?" Well, the parents, well, I guess 10:30. I don't know. Well, they started looking at their going in and peeking in their kids. They were playing video games until 2 in the morning. Then
yeah,
they get up at 7 o'clock to go to school. They've had 5 hours sleep. There's no wonder that they're having all the issues with behavior and grades and all these other things. And these blue screens are they are detrimental. People, they are not good. And so, I mean, at the very least, get your children some blue light filters and take their devices away from them when they go to bed. Do not let them have their phones or their iPads or a television in their room.
yep,
The best thing you can do for them.
yeah. When I was teaching, I would receive emails from students at like 3, 4 in the morning on a school night asking, they're just now doing their homework and having questions. I'm just like, what are you doing up at 3 in the morning? This is insane.
Yeah.
I will link in the description Dr. Sachs's interview. There's also an iPhone hack I will link as well where you can, because on your iPhone, you can set it on night mode where it reduces the blue light. It does not take it away completely. There is a hack where you can actually turn your screen to completely red light. So, I mean, it makes your screen red. So it's not ideal viewing, but at least my husband and me, 2 hours before bed, we always turn that on so that if we need to be on our phone, I mean, there is no blue light at all. So I'll link that below as well. And so I have just a few questions and then we can call it a day from some moms on Instagram when it comes to sleep. So the first question was my son breathes. This mom actually sent me a photo of her child sleeping, which I was like, that's a great first step. But she said her son breathes through his nose when he's sleeping, but his mouth is always open. Would you say like what are your thoughts on that? Could it just be positioning? Is he actually breathing through his nose?
I would say that no. I mean, he may breathe through his nose some, but if his mouth is open, I would look, if she could take a little flashlight. Where's his tongue?
Mm.
I mean, it's very rare that the tongue is sealing the roof of the mouth off and is open at the same time. Now, when kids go through myofunctional therapy, that's one of the exercises they do. They, seal the tongue and open because we want to make sure they can open really wide and get that seal because that means that they've got good oral competence. But when you're sleeping, normally your tongue, if your mouth is open, your tongue is not up in the roof of your mouth, and you're breathing through your mouth. Maybe you're breathing some through your mouth and some through your nose, but
Yeah.
you should be 100% nasal breathing. So I would take that as a sign that he's a mouth breather. So
That's a good
what
point
what
about
we say at TBI is tongue up, lips closed, healthy breathing through the nose.
I was just about to say that. I think about that all the time. That's great advice too. Yeah, where is your child's tongue when they're sleeping? 'Cause I don't
Yeah,
think most parents know you want it up at the roof of their mouth,
right.
not
Well,
down.
I know Dr. Corridor when like when Evelyn was born or Miles that when we have parents come in with infants, if the infant is asleep, she'll just gently take their lip and pull it down. And what we want to see when we see that, we want to see the back of their tongue,
Hmm.
that part, because that means their tongue is up in the roof of their mouth. And so, we can evaluate that even in an infant.
Yes. Okay. So next question. This in this particular question, the child is 3, but for most younger children, 3-year-old with no gaps in between teeth, is this always a sign that the jaw is too narrow?
That's a good question. Here's how I will answer that. The sign that a jaw is ideal is going to be little gaps. The teeth are lined up straight, and there's a little gaps between each and every one of them. So if the teeth are any crowded at all and have, if they're crooked, there's not enough space. If they're lined up perfectly and there's not enough space, then there's a possibility that it could still be their jaw could be developed properly. But I know for a fact if I see a 5-year-old and all their teeth are nice and even and there's spaces between each of them, they're going to have a 31, 32 intermolar measurement every single time. So if they're, if their teeth are any crowding at all, I would say, yeah, their jaw's underdeveloped.
Is crowding considered touching or specifically overlapping, crooked?
When we say crowding, we think of overlapping. Yeah,
Okay.
there. Yeah,
Okay.
and it doesn't even have to be one tooth behind the other that crowded. But
Okay.
if they're, yeah, you're not going to see any spacing, and you're going to see teeth that are, instead of in a nice arch, you may have one here, and one here like that.
Okay. That's good because I didn't. I when I thought of crowding, my mind always went to just like, yes, crooked, but like no space, which could be a sign too,
Yeah,
but
yeah,
that's a good clarification. So this next question was just toddler grinding teeth, question mark. I would assume that is not, a normal sign.
right. Yeah, and I meant to talk about that when I was talking about it earlier. The fight or flight, your body, you're going into the deep sleep, REM sleep, adult or child, um, and your airway starts collapsing, and your carbon dioxide buildup goes higher, and the brain senses that. So what happens? One of the things the brain does is it pulls you out of REM sleep into light sleep, and there's a clenching, grinding that occurs, and that's the body's way of making those muscles around your airway, which the airway is just a functional space. It's a space that's formed between the tissues all around it, and so those are muscle. So if you tense a muscle up, it's got less of a tendency to collapse. So the airway starts collapsing. The brain senses the carbon dioxide buildup. The brain then triggers the masseter muscles to clench and even grind. That's where clenching and grinding in children comes from because they can't sleep well. So if your child's clenching and grinding during the sleep, they have a sleep related breathing disorder.
Great. This is the last question. This question is specifically regarding a 7-year-old, but just for children in general or adults. Um, is a tonsillectomy always necessary for enlarged tonsils and a mouth breathing? And how to know if a tonsillectomy and adenoid removal is actually necessary?
Yeah, that's a good question. There's not a direct answer to it, but here's how we answer that. If if the patient with their if there's the tonsils are definitely swollen, but if we can get them breathing through their nose and we do some food sensitivity testing or allergy testing, mold testing, we try to, first of all, if they're breathing through their mouth, those inflamed tonsils are never going to go down because they're just catching all that debris from the patient breathing through their mouth. Um, but if we can get them breathing through their nose and we're eliminating anything that they may be allergic or sensitive to, we can, I have no problem in observing and checking the tonsils again in 6 months or 8 months. And of course, we would have recommended ENT see this. And then if the ENT says, oh, I think they need to come out, then maybe the ENT and I have a call and I'll say, hey, look, here's what I want to try. Are you okay with this? And if the ENT says yes, yeah, that makes sense. Let's do that. Because honestly, ENTs don't like to take tonsils out. They get they get paid very little for it. There can be a lot of complications that they never really get compensated for. And so it's just natural that they don't want to do that. And so whenever they have a doctor like myself that says, hey, here's my thought on can we try this? They're like, yeah, let's give that a try. That's great. Now, if I have a child whose tonsils are so swollen that they cannot physically breathe through their nose, they can barely breathe through their mouth, and we see those. We look in the back of the throat and you can't see anything. All you can see is the right tonsil and the left tonsil, and they're kissing each other. That would be a case where I would say, Mom, Dad, I'm not for removing body parts whenever possible, but this kid's got to breathe. They
Yeah.
need to come out.
Yeah. Okay.
So
So
in
you would
most cases, it's a let's watch and see. Let's do ABCD. Check it again in 6 months. Look and see what it looks like. That's the most in most scenarios. That's the case. That's what we see.
say similar to, a child received an ADHD diagnosis before resorting to medication, seek out a sleep
Right.
airway dentist first. Similar,
Right.
if you've seen an ENT first and they are suggesting tonsil or adenoid removal, maybe consider seeing an airway dentist before
Yeah.
moving forward. Okay.
Or have the airway dentist and the ENT talk
Yeah.
because um, again, if there's can be some non-surgical ways to start reducing those tonsils, and then the child can start nasal breathing, um, and then eliminate any foods that might be adding to that or exacerbating the
Okay.
inflammation of the tonsils. That's always the best way to go because our tonsils are there for a reason. They're kind of like they're kind of like the pharmacy of the body. They have they eliminate a lot of things that come through our body when we do breathe through our mouth. But if we're just overbearing them, they're going to get swollen. So the tonsils are supposed to be in our body. I don't like to remove body parts because the way that we're made by our creator, all those parts have a function. And you can live with one kidney, but two is better. You can live without tonsils, but having your tonsils is better.
Okay. So if there's a parent that's just now listening to this, their child has already had tonsils and adenoids removed, and they're like, well, shoot, I didn't know any of this. Can you just give this, and then this is, I think oh no, I do have two more questions that are
Mm.
just general dentistry related, but can you maybe give some encouragement so this parent isn't thinking thinking like, oh my gosh, I've set my child up.
Yeah, no, it's not the end of the world. I mean, there's nothing you can do about that. So just everything else we've talked about in this podcast, do that. Have your child evaluated for airway and sleep, and they can live a normal, healthy, long life without their tonsils. So um, it's just that if I had my druthers, I would rather the tonsils stay in there. But yeah, if they're gone, they're gone. You can still be very healthy and live a very healthy, productive, thriving life without your tonsils.
I always like to throw in some encouragement because I think it's easy for podcasts and things on the internet to talk about all what you need to do and what you should
Yeah.
do. And it's like, well, it's too late for me now. And now you're sitting here like, well, shoot. And it's like, okay, it's not like you said,
Well,
it's
like we said at the beginning, it's never too late.
yeah,
Never
yeah.
too late to from where you are to move forward and to improve.
Okay. Okay. Well, unless there's anything else you want to add in regards to sleep disorders, oral restrictions, I just had two more kind of changing the pace. These questions come up a lot about toothpaste and fluoride. I was hoping to maybe just touch on that for a second. But before we move into that, is there anything else you feel like you need to add?
No, I think maybe we should have another podcast that goes into more specifics on how we treat
Okay.
underdeveloped jaws.
Okay.
Um, I think that would be a great just focus on that because there's so many different ways to do it, and they're all good. And for some kids, treatment AB is better, and for some kids, treatment D, E, and F is better. And so it's more or less where that child is, and there's a lot of factors that go in it. We have a lot of our patients complain about all the intake forms that we require, but we are doing that for a reason. We read every single word of those intake forms because it tells a story, it paints a picture, and it helps us develop a treatment plan better. So maybe we can do that at another
Yeah.
podcast. So
Yeah.
I
Just
think we've covered what you wanted
generally,
to cover today pretty thoroughly. So
yeah.
been really pleased with everything.
But just generally, when you obviously are looking at adults, it's going to look different. But when you're looking at children, for the most part, whatever treatment is chosen, it's typically pretty minimally invasive, right?
Yeah,
I
always
mean,
minimally.
obviously, if we're
Yeah,
doing tonsillectomies, that's a little bit more
right,
invasive. But
right.
I think sometimes
No,
parents
with
are,
a child. With a child, it's either going to be a growth guide, um, or some type of expander with a gear, or a light wire expander in biointegrity neural integrator like an ALF appliance. And there's we can talk
yeah,
forever on all of those, but yeah, it's non-invasive, very conservative, but makes a significant difference in the
yeah.
child's life.
Um, Okay, I'm actually going to link this as well. There is a mom influencer on Instagram. Her handle is Raising Well Kids, WELL. They're based in Canada. I'll link her as well. But her son, I want to say he's like 7, is currently going through seeing an airway dentist, going through expansion, and she has a highlight about their dental journey. Just recently posted a picture of her son when they first started, and then 4 months later, and the difference is unbelievable,
Yeah,
especially in his eyes. I think it's a great visual for people to physically
yeah,
see the benefits of this. So I'll link her below as well. So
good.
while I have you here, we're almost done. I do want to ask, because I know a lot of moms have this question, and specifically about fluoride toothpaste. Is it
Mhm.
necessary? Is it toxic? What should they be using instead? What are your thoughts?
Yeah, fluoride is a toxin. I used to be all for it. I'm not anymore. The research has shown that there's too many negative things with fluoride, and on the if fluoride were the only thing that prevents dental caries disease, okay, but the dental what we see happening to the teeth from a standpoint of tooth decay, that's a systemic problem. That's not from, well, even a lack of home care. If you're eating properly, if you're exercising properly, if you're breathing properly, if your blood chemistry is ideal because you're taking in the right things, the pH in your mouth is going to be, it's going to be an alkaline environment. But when you're drinking all these sugary foods, yeah, it gets in your mouth, but you could drink, a Diet Coke and then rinse your mouth out and brush really thoroughly. If you're doing that on a regular basis and you're eating these fruit snacks and all this gooey food and you're eating high fat, trans fat food, your body's going to stay in a state of cellular inflammation, and your oral pH is going to be conducive for building up these horrible anaerobic bacteria, and you're going to be more prone to tooth decay. And I've got lots and lots of patients that come in and they've had tooth decay, and they're using fluoride and they still get it. So you can cut out all fluoride, and you can take the proper supplements and minerals. There's a really good book called The Dental Diet. Um, oh, I've gone blank on the author. I'd actually asked him to be on the podcast at one point. He said, yeah, so we need to pursue that. Oh, gosh. Anyway, the book, it's the only book out there called The Dental Diet. He's an Australian dentist. That book, especially chapter 4, has an amazing chapter of
Dr.
vitamins,
Dr.
supplements.
Stephen Lynn.
Stephen Lynn, yeah. Our diet determines whether we have tooth decay or not using fluoride. So it's the bottom line is fluoride is like having a fire truck outside your house, and you're going to set your house on fire every day, but it's okay because I got a fire truck out here that can put it out. Well, why not have your house fixed so it doesn't catch on fire every day? Then you don't need the fire truck. So if you're feeding your body what it needs and you're breathing well, our body is a system. It takes proper nutrients, it takes proper fuel, it takes, our intake manifold and exhaust manifold need to be working properly, i.e., we need to be breathing properly. So breathing and diet, and you can't have a healthy gut if you're not sleeping and breathing correctly. So gut health is extremely important, but trying to do that and not sleeping well is you're compromising that. So breathing well, sleeping well, diet, gut health, if all that's in place, you don't need fluoride. You're not going to have chronic dental disease. If your arches are developed and your teeth come in straight with, the proper amount of space, you're not going to have dental disease. So it's, on my answer to fluoride is not just simply yes or no, because I know people, if you say no, the people are going, well, what do we do?
Yeah.
There's a toothpaste called Dave's toothpaste, and it's the one with hydroxyapatite in it. I really like because it can actually remineralize teeth. Doesn't have any fluoride, so I recommend that toothpaste. Um,
Can you touch really quick on there's hydroxyapatite and then there's nano hydroxyapatite. There's
yeah, now you're
um
getting in. You're getting into a realm where I'm not really sure. I just know nano. The term nano in general, and I look at it in different spectrums throughout, in my profession, just means you've got more of uh, the chemical, but in smaller cellular forms or anatomic forms, so they can penetrate better. So that
um,
I would assume that's what that means. It's still
I,
hydroxyapatite is just in a different form where it can be absorbed by the teeth better.
yes, I wanted to point out if my computer's not going to be slow. And you tell me if you think that this sounds correct. Nanohydroxyapatite contains, this is from my oral guide, contains smaller particle sizes, which allows deeper penetration into the enamel, might typically be better suited for sensitivity and early erosion, whereas non nano works more on the surface
Yeah,
and reinforce the outer layer. This might typically be best for overall enamel maintenance and surface protection.
yeah,
I
yeah.
know there's some debate with nano crossing the blood brain barrier and
Yeah.
some studies that show there could be some toxicity effects. So I always feel like maybe a good, you know, if somebody's concerned about that, maybe don't use nano every single day.
Right.
I don't know. I guess it's up to the person's discretion there.
Yeah, and that's a really good toothpaste. And the reason that I just don't automatically say, "Oh, use this," because we we've been conditioned in our society that is like a good friend of mine. He had high cholesterol. This is back when cholesterol was the big thing.
Yeah.
So we were in a Bible study every Friday morning, and he would always just get some fruit and oatmeal. One day he comes in, he gets bacon and eggs and greasy this, that, and the other. And I said, "Hey," I said, "What's where's your?" He said, "Oh, my doctor put me on Lipitor. I can eat anything I want now. So
Yeah.
I'm more for the lifestyle change than you don't need that
Yeah,
toothpaste
yeah,
rather than, but if you are going to use a toothpaste, even if you do the lifestyle change, use this with no fluoride.
yeah.
Um, but let's look back at why you would even need fluoride in the first place. It's
Right.
because your body's not able to combat this virus that's burning in your mouth from malnutrition and poor exercise and poor breathing.
Yeah. So would you say that, in a perfect world and everything's in harmony, you might not even need toothpaste, just brushing with
Yeah,
water?
you could. Well, let's, back in before the Industrial Revolution, even, back even hundreds and thousands of years before that, when people would, pick a rootstock out of a, pond and they would chew on it and that would stimulate, but it also clean the teeth. And, um, with these sugary, um, non-substantive foods that we eat, we're just bathing our teeth in sugar and other chemicals, and then we inside our body, we've got all of this um, in our bloodstream that's causing a high pH, and high pH means inflammation. So, I mean, low pH, I'm sorry, low acidic pH. Low pH means inflammation, and inflammation means bacteria, and bacteria mean, eat holes in your teeth. So, theoretically, yes, you would not need toothpaste at all. There would be need for some kind of mechanical removable of, after you've eaten food
Yeah.
and things like that. But the toothpaste there are good toothpaste like the one I told you about. And Jen's toothpaste too is JEN. That's a good toothpaste too. It's got hydroxyapatite. So, I would recommend one of those, and it certainly won't hurt anything. I'm not going to tell people that, hey, you don't even need to, you know,
Yeah.
brush anymore. I would still recommend that. I mean, we do live in a civilized society where, we want our breaths to smell good and we want our teeth to look nice and white. So nothing wrong with that. But I would stay away from the fluoride because you don't really need it.
Yeah, I was gonna say I think that most parents probably will have a hard time getting on board with no toothpaste at all. So for those that are
Yeah,
looking,
well, if you can do something that's not hurting anything,
yeah,
then that's
so
fine. Use it.
hydroxyapatite, and then last thing before we go, what about xylitol toothpaste? Is that a decent
Mhm.
option as well?
Yeah, xylitol is a natural anti-inflammatory. It's naturally produced and by plant, and it is an excellent anti-caries. It caries meaning dental decay. It. I know that there's a company that is a dental manufacturer in 80 countries in the world. I used to lecture for them, and they're a great company, but they do a lot of um, missionary type work around the world in underdeveloped countries, and they will take xylitol gum or xylitol lozenges and give them to the kids because they can't, they're not there all the time. They can't be on these kids. They can't, even if you give them some toothpaste or toothbrush, you don't know they're going to use it, but they'll eat this candy. And what they found in the societies that they did that, and they would come back every year and check on the tooth decay was reduced by over 50% in every one of these societies or cultures that they introduced the xylitol um,
Yeah.
gum lollipop. You can get them in lollipops. You can get them in gum form. You can get xylitol in like a lozenge. Um, I know someone very near and dear to Alex and I both had a really severe mental brain issue 6 or 8 years ago, and it was a frontal lobe dementia, and he was just craving sweets, and he was in an institution, but of course the sweets were just going to cause all of this, for his whole body, just horrible effects. So I gave his wife a big bag of xylitol lollipops, and she took them to him, and so he loved them because they're sweet, but they're not going to harm anything. So I'm a big fan of xylitol as not only an oral rinse or an oral paste, but also xylitol spray. There's a product called Clear, XLEAR. It's a Scandinavian product, and in Scandinavia, XL is pronounced K, like, or X is pronounced like a we pronounce a K or a C. So XLEAR is how it's spelled, but it's pronounced clear. It's a great nasal spray for reducing inflammation in the nasal passages. So I would promote. I would say yes, xylitol all the way. Nothing wrong with
And
that.
most, at least that I've seen, most of the hydroxyapatite toothpastes include xylitol.
Yeah.
Um, anyways, so okay, well, I think this has been very informative, and I'm hopeful that this will answer a lot of people's questions and give a lot of people some guidance and some hope. So I appreciate it. We'll do another episode at a later date with Dr. Corridor, kind of asking these same questions specifically for infants and young toddlers, and
Yeah.
then we'll have to set up another one to talk about more detailed treatments.
Great. Awesome.